Hi, my name is Sanjay Mukhopadhyay. I'm a thoracic pathologist at the Cleveland Clinic, and today I'm delighted to have my good friend and colleague, Chuck Sturgis, who is a cytopathologist at the Cleveland Clinic, here to have a discussion with me about a very interesting case where we'll be discussing both the cytology and the histology of the case. So welcome, Chuck, and take it away.
Sanjay, thanks for having me. The case we're going to go over is an elderly man with a unilateral pleural effusion. And Sanjay's provided us here with a chest radiograph, and he has a nice big red arrow indicating that there's a unilateral effusion, and it fills, from the mid-lung field all the way to the base on the right side. And this is a CT scan showing a correlating image, but from a different perspective. And I think from the cytology side of working this patient's effusion up, one of the questions I would have, both from looking at the imaging and from interacting with the radiologist or reading their report is there a parenchymal lung lesion or not? Because often we get a history of only just pleural effusion without much clinical information, and then I go to the electronic medical record and try to, dig things out of there.
Yeah.
So at least in this image, I don't perceive a parenchymal lung mass, and I do see this kind of posterior dependent large unilateral fluid collection.
That's true. So Chuck, one thing I've noticed in these large pleural effusion cases, especially the unilateral large pleural effusion, is that, here you have some lung parenchyma left to evaluate. Sometimes there isn't any. It's just completely, the lung is sort of collapsed completely and you just can't see what's in the lung parenchyma. Or, if you're looking for a rind around the lung, you can't even see that because the whole thing is collapsed.
Right.
So all you get to see is that there's a unilateral pleural effusion, and you don't have too much useful information from the radiology. So let's move to the cytology. So in this case, we were discussing the cytology and the histology were done at the same time, so we had the chance to look at both together.
Which is a luxury for the cytologist, because often we don't have a biopsy or we have to wait a week or two to get a confirmation.
Right.
So here at the Cleveland Clinic, we process our serous effusion cytologies as two slides. A thin prep, which is kind of by definition Papa-Nicolau stained, and then we make a cell block from any sample that has enough cellularity to allow that. So that's what we had in this case. In other centers, they may use different cytopreparatory techniques and different stains. So the first image that I have to show you is a low power shot, which is, I took this to kind of emphasize the fact that this specimen is actually a very low overall cellularity. So in the background here, we have some fibrinous material and maybe a few tiny white blood cells that are in these little fibrinous clots. And we really have only one in this low power field nest of epithelioid cells to look at. So I think the next picture is that same group of cells, but on a much higher magnification. And one of the things that I like to do when starting to examine a fluid case is to find something in the background that I know is a benign cell and that I know the cell type, so that I can use that as a reference to compare to maybe cells that are in question or cells about which I'm not certain. So in this field, there's a lymphocyte here off to the side, which is just a small blue nucleus. And I think that's a great size reference. The nucleus of the lymphocyte is about the same size as a whole erythrocyte, so maybe 7 to 8 microns. So the cells that are making up this big three-dimensional aggregate are much larger in size than a normal cell. The benign cell that we would also like to compare to, and unfortunately in this particular case there were very few to know of those cells, are benign mesothelial cells. Right. And this just happens to be an effusion that doesn't have many or any of those cells. So this group, I think it's probably on the order of a couple of hundred cells together. The cells are not in a flat plane. Instead, they're piled on top of one another, and if we had the luxury of being able to focus up and down, we would see that we have 3 or 4 cells in thickness here. I generally start with looking at the periphery of the three-dimensional group. The classic teaching is that in adenocarcinomas or metastatic adenocarcinomas, one will find what we call a common border, meaning that the edge of the group doesn't have extruding nuclei or portions of cells pushing out of the group. Here we have a little bit of hobnailing where we have one nucleus extending from the edge of the group, but I think the majority of this group has more of a common border. And then the nuclei within are large, kind of an increased nuclear to cytoplasmic ratio, open chromatin, and big nucleoli.
So is it fair to say, Chuck, that at this point, your antennae are really, I mean, you're very leaning malignant here?
Yeah, I think this is a malignancy.
Like a malignancy.
And the question is, for the most part, in my mind, is this an adenocarcinoma of some type, probably from lung,
right,
since we weren't given a history of anything else?
Right.
Or is this, you know, a mesothelioma, which, since the imaging isn't definitive for either, you know, no parenchymal lung mass, and also not a nice, you know, encompassing rind.
Right.
So that's the main differential diagnosis, I think. So let's go to the next image. So this is a smaller group of lesional cells. And once again, I have kind of a normal leukocyte here in the background that we could use as a size comparison. This cell is, you know, maybe the nucleus here is 6 or 8 times the size of the normal nucleus. So cell size is a good indicator for neoplasia. There are irregular nuclear membranes. They're not smooth and round. I think in this group, this cell has a more abundant cytoplasm that has kind of a frothy look to it. But this little cell has a more discrete cytoplasmic border and a higher nuclear cytoplasmic ratio. These 3 cells are also kind of hobnailing. They're sticking out as opposed to having the smooth border. So this isn't entirely straightforward.
Yeah.
This has some features that could go either way for adenocarcinoma versus mesothelioma.
So definite for malignancy, but not definite
Right.
for whether it's adeno or
And I
meso.
think the definite for malignancy would depend upon who you're asking, because there are some pathologists, some thoracic pathologists as well as cytopathologists who would not render a diagnosis of malignant mesothelioma on a fluid,
Right.
no matter what the morphology was.
Right.
I have done that before, but you have to have all the stars aligning to make that happen.
Right.
So yeah, I do think this is a malignancy, but I need more information.
Sure. Can I ask you one question, Chuck?
Yeah.
I learned this, you know, when back in my cytopathology days, or when I was a learning cytopath. This point you made, I really like that point about the irregular nuclear membranes, that it's not round and symmetric.
Right.
And the way they taught it to me, my teachers taught it to me, is they said there was this sort of 4-quadrant rule, so that if you broke the nucleus into 4 quadrants and each of them were identical, that's kind of a reassuring finding. Whereas each one of them are different, like in this case, if you broke them into 4, each would look slightly different than the other. That would be sort of a surrogate for the irregularity of the
that's great. And I was taught the same thing, and I sometimes teach that to our trainees here.
Okay, great. So we are now on another.
So now we're on really high power here, and this is a different 3-dimensional aggregate. Here, I think the edge could be interpreted either way. There are some parts that look like more common border along this edge. And then there are other areas where we have individual nuclei that are protruding a little bit. One of the things that I think is nice about this group, and the reason why I chose to make a photomicrograph, is that I think intrinsic to this aggregate of cells, there is a cytoarchitecture. And I think architecture is something that people who aren't cytology aficionados have maybe struggle a little bit more to discern within cytology specimens. People who are used to histology are used to seeing things cut and only in one plane. So here, if I use this little marker, I think that these cells that are intrinsic are arranged in somewhat of an acinar or glandular pattern, and if I put the marker in the center, that's kind of analogous to a potential lumen.
Yeah.
And then here is another, roughly circle of cells with a potential lumen. And as you see those, and then you look, further, you find more and more of these acinar structures that are intrinsic to these large fragments. So, adenocarcinomas can have this back-to-back, almost cribriform glandular growth pattern, but mesotheliomas can be tubule forming. And so that, I think, is something that might make me favor more of an adenocarcinoma, especially given the overall appearance, but isn't specific.
Right.
So if you see that, that doesn't mean, oh, this is not mesothelioma.
Right.
And it would depend on the type of mesothelioma.
Sure.
The other thing that I think is worth kind of pointing out here is the cytoplasm. On Highpower, we can see that some of these cells do have a much more abundant, foamy to almost kind of microvacuolated cytoplasm. That might fit a little bit better with adenocarcinoma. When we're trying to decide about non-small cell carcinoma versus mesothelioma in cytology, the classic teaching is that adenocarcinomas have a more syncytial cytoplasm. So the cells are kind of all floating in a common sea. Squamous carcinomas, which we don't see as commonly in fluids but can happen, might have intracellular bridges.
Sure.
Whereas mesotheliomas have those beautiful microvilli on their surfaces that create a windowing artifact between the cells. So looking at the cytoplasm and the nature of the cytoplasm as it kind of moves from cell to cell can be helpful. So I think I would be favoring, in this instance, adenocarcinoma, but I would want to pursue a workup.
Okay.
So this is the first shot from the cell block, which is the second slide that we routinely make here at the Cleveland Clinic. The background has this kind of particulate, granular, proteinaceous material. In the background, we have some scattered white blood cells, which are very small in comparison, and perhaps one mesothelial cell that we could use as a size, comparator. And then one of the things that I think stands out in the cell block a little more than it did in the cytology is the degree of pleomorphism or anisonucleosis. Some of the lesional cells are very small, whereas others are, 6 to 8 times the size and have nucleoli that are larger than the background leukocytes. So, this for me is an overtly cytologically malignant process, and it's just trying to decide what name we would best give it.
Right. So that brings me to the question of, if we didn't have a corresponding biopsy and this were the only material we had, you would pursue it? Would you stain it?
So, 25 years ago, we might have done electron microscopy, which no one does anymore. Today we would do a battery of immunohistochemical studies, and since we have a nice cell block with a large number of these particles, we should be able to pigeonhole the cell type and then correlate that with the clinical setting and give a definitive diagnosis. I do sometimes make definitive diagnoses just on morphology, but I generally do that only when the clinical setting, the imaging, and the morphology are all congruent and classic for whatever the disease is. In a case like this, I would not do that. I would pursue an immunohistochemical battery.
I see.
And I would do some stains that would favor mesothelial lineage, and then others that would help us rule in or rule out adenocarcinoma, probably of the lung.
Okay. So in this case, of course, we had a corresponding biopsy. So correlating this with the biopsy, I think we were able to come to a cytologic diagnosis.
Yes.
Right? It was called positive for malignancy and adenocarcinoma. So let's move to the biopsy part of the discussion. And so the pleural biopsy was done by a thoracic surgeon, and the surgeon's note mentioned a rind of pleural thickening, which I find very useful information. Of course, you can have a rind of pleural thickening even in an empyema, but generally when I hear the word rind, or if I hear nodules studding the pleura, my antennae are up for a malignant process. And also he said, the surgeon mentioned their metastatic disease, which suggests to me that they felt that the distribution and the number of nodules was large enough that they were suspecting malignancy clinically. So I use that information. I always look at the surgeon's note, the intraoperative note, and I find that that's one of the most useful pieces of information in the differential between benign versus malignant in a pleural biopsy and also mesothelioma versus adenocarcinoma.
You're fortunate in the fact that in doing surgical pathology, you have a surgeon's note.
Yes.
Often, you know, when in cytology specimens, the person who is diagnosing the effusion, like the primary care doctor, isn't going to write a surgeon's note. And the patient is often sent to someone who's a proceduralist, like maybe in interventional radiology, to have the thoracentesis. So I think the cytologists have maybe a little bit more of a struggle in the sense that the patient hasn't seen the surgeon, yes, and we don't have their perspectives.
Yes.
So,
yeah.
Sorry to
point,
interrupt.
no, your point is well taken. I mean, there's a crucial piece of information missing,
right,
when you're looking at
yeah,
it one step
right,
before. Yeah. So the biopsy actually shows an infiltrative malignant process, and you can see these big, malignant cells, epithelioid malignant cells. I'll have to confess, when I saw this case, I thought it was mesothelioma based on this morphology. They're sort of cuboidal cells. They're not, the gland formation is not that obvious on pathology. They're sort of solid nests. The one thing that does bother me a little bit is that it is clearly malignant. At least to my eye, this is clearly cytologically malignant. And that usually is not the case with mesotheliomas. At least epithelioid mesotheliomas, in my experience, they are a little bland,
yeah,
relatively bland. So you know they're malignant because they're infiltrating, but they're not all that overtly cytologically malignant. So I really was thinking this was going to turn out to be a mesothelioma. I hadn't seen the cytology at that point. So I worked it up. I worked it up with stains. This is what the high mag looks like. Again, it's sheets or nests of cells with abundant eosinophilic cytoplasm. Correlates pretty well with what you saw.
It's very nice, yeah.
So almost identical morphology. And you can see the mitotic figure. So the question, the really important question of whether this is malignant or not is not a question, just as on cytology it was clearly malignant. So the only question is it mesothelial or not? So what I did was a keratin AE1/AE3, and I don't always do this when it's clear that it's either
right,
mesothelioma or adenocarcinoma. Maybe here I was thinking, in the back of my mind, could this be melanoma or some other epithelioid malignancy? So I did a keratin AE1/AE3, and you can see that it's a positive. So we're down, the differential has been narrowed to those two things that you mentioned, Chuck, based on morphology. So the stains that I do, and everybody has their favorite mesothelial, non-mesothelial
right,
stains. The stains that I do almost invariably includes, on the non-mesothelial side of the equation, a CEA and a MACH31. Those are my favorites. I sometimes add in a BREP4. Why I add a CEA is, although CEA is not perfectly sensitive for adenocarcinomas, and it misses some kinds of cancers from some sites, it's very specific. It's one of the most highly specific adenocarcinoma markers. So, the sensitivity is around 80%, but when CEA is positive, you can be very close to certain that that's not a mesothelioma, and it pushes you towards the adenocarcinoma side. So here CEA is clearly positive. The other marker, as I said, I mentioned, is MACH31. MACH31 is more sensitive for adenocarcinomas, but in my experience can sometimes stain mesotheliomas too. So it's not 100% specific, not even close to 100%. But the staining is usually very crisp, and a strong diffuse MACH31 sways me in the direction of an adenocarcinoma. And then on the reverse side, which I haven't shown here, my favorite markers are, I do usually calretinin, CK56, and WT1 for the mesothelial, on the mesothelial side. And if things get tricky or there's a sarcomatoid element, I add a D240 as my fourth marker. But I tend to do multiple markers or a panel. But I know that different pathologists do different panels. I don't know, do you have a favorite panel?
I would do exactly the same panel you just described. The only thing that I would add, which is maybe more old-fashioned than related to either cytology or histology, is I might do a mucin stain.
Okay, yeah.
Just because it's inexpensive, and if it's strongly positive with intracytoplasmic droplets, then I feel like I might not have to spend all the money and time to do all these immunohistochemical markers.
Makes sense.
And if it's positive, though, it wouldn't help me to determine the site of origin, like saying that it's lung versus GI, et cetera.
Right.
So I would probably end up doing some additional staining, even if the mucin stain worked.
Was positive, yeah. So MOC31 was positive here, and then the one thing that I always add on the non-mesothelial site is, because I'm dealing with pleural effusions,
Right.
not with peritoneal biopsies, is I add a TTF1. Now TTF1 is great because essentially if a TTF1 is positive in a pleural sample in malignant cells, you've basically established basically established the diagnosis. Especially if it's clearly a non-small cell carcinoma, you can say that this is an adenocarcinoma and it is a lung primary. The multiple studies. Yeah, go
I
ahead.
was just going to say the only potential pitfall being
Yes.
if the patient has thyroid cancer.
Oh yes, absolutely. So if there's a history, that completely changes the game.
Yeah.
If there's a history of renal cell carcinoma, thyroid cancer, ovarian cancer, you have to approach the whole differential differently.
Right.
But for a patient with no history, where this is the only site of disease, you're basically limiting yourself to the lung adenocarcinoma versus mesothelioma differential diagnosis in most cases. And then their TTF1 essentially establishes the diagnosis of adenocarcinoma. I will add here that we use the clone that is the more specific clone, 8G7G3/1. That's what we use here at Cleveland Clinic. And that is a very specific clone, as to my knowledge has never been reported in mesotheliomas. But there is a clone, I forget the exact name now, but there is a clone that has been reported that is positive in sarcomatoid mesotheliomas in some proportion of cases. So people who use that clone actually even see in squamous cell carcinoma. So you have to be very careful about what clone of TTF1 you're using before you put the kind of weight that we do on our cases. So 8G7G3/1 TTF1 is really a good marker, and here establishes the diagnosis of adenocarcinoma, and we can say that it's consistent with a lung primary. So Chuck, between cytology and histology, we established a diagnosis here. So I just wanted to take this opportunity to discuss just the differential diagnosis.
Sure.
And how we put together the clinical, the radiology, and other histologic and cytologic parameters here. So I try to think of it as a table. And this is my very amateur diagram of a table standing on 5 legs. I've actually written about this on Twitter before. But how I think of it is that mesothelioma is a diagnosis that stands on 5 legs. And ideally, in an ideal world, you would want all 5 legs to be intact.
Right.
And so the 5 legs that I like to see are that there's an elderly man, usually, an elderly man with a unilateral pleural effusion. And we know that leg will not always be true. Sometimes women have mesotheliomas. Right. Younger people, it's not always elderly. But in most cases, you want to see somebody who's in their 70s, 80s with a unilateral pleural effusion. The second thing I'm looking for, as you mentioned when you showed the radiology, is that I'm looking for a unilateral effusion with a rind, not with a lung mass. So if I see a solitary lung mass, I'm already thinking this is not mesothelioma. Right. So I want to see a unilateral effusion with a pleural rind or pleural studding by nodules on the CT scan, and sometimes they can tell on CT that is the case. So that makes me more confident that I'm dealing with a mesothelioma. The third leg which we discussed was what the surgeon sees at the time of the biopsy, which of course the cytologist most of the time doesn't have that information. So that leg is missing for the cytologist, but the surgical pathologist does have that information. And you want to know, did the surgeon see a rind around the lung? Did they see multiple pleural nodules? That's very helpful information. And then what I think is really the key leg, the one that really can't be missing, is you have to have either cytologic or histologic evidence of malignancy. You have to have malignant cells. If you don't have that, all of that stuff can be potentially misleading unless you have definitive evidence of malignancy. And then once you've decided that it is malignant, then you want to do immunohistochemistry, especially if it's an epithelioid tumor, to tell whether it's mesothelioma or adenocarcinoma. Is that reasonable, Chuck, like that table kind of approach?
This is a great 5-legged table.
Okay, thank you. So the idea is to have all 5 legs intact and to have a sense of which legs can fall out, but still the table would stand and you would be able to make a diagnosis of mesothelioma. Now, if you flip the situation, what would you expect with an adenocarcinoma? And we're talking mostly of a lung adenocarcinoma. Most of the time, these patients will be elderly too. They tend to be slightly younger than the mesothelioma patients. Instead of the 70s, 80s, they can be 60s, 50s, but there's overlap, obviously. Again, with a unilateral pleural effusion, it's very helpful to know that the patient has a solitary lung nodular mass and then has pleural studding, but like Chuck mentioned, often you don't get that information or the CT doesn't show it. Then it's helpful to see that the surgeon saw at the time of the biopsy pleural nodules, and we had this, in this case, we had the finding that the surgeon saw something that looked malignant. Then we want to have cytologic or histologic evidence of malignancy. In this case, we had both cytology and histology. And then we want to have classic immunohistochemistry. We want the adenocarcinoma markers positive and the mesothelial markers negative, which in this case, we had everything. So in this particular case, we had everything except a classic radiology. I mean, we didn't have a lung mass there, but we had an elderly person, we had the surgeon's note, we had cytology and histology, and we had classic immunohistochemistry. So I think in this case, we had enough evidence that even that one leg fell off, the table still stands.
And I think when the radiology shows you a massive effusion, you don't know what's being obscured by the large effusion.
That's right.
So there probably is a lung mass. We just can't see it because of what's going on with the patient's physiology.
That's correct. So I think with that, we'll end this presentation. I hope that our audience has learned something about the approach to pleural effusions with this particular question of adenocarcinoma versus mesothelioma, benign versus malignant. I'd like to thank you very much, Chuck, for participating with me.
I'd like to thank you for the invitation, Sanjay.
Thank you for coming. Thank you for listening.